This afternoon, I'm going to talk to you about primary spinal syringomyelia, which is syringomyelia that originates entirely at the spinal level and is distinct from syringomyelia, which is related to another not uncommon situation called Chiari malformation. And I want to thank the organizers of this meeting, particularly Patrice Chablin, for the invitation to speak on the subject. Some of you may have heard me speak about this before, and if I'm repetitious, I apologize, but I also have to say that unfortunately there has not been new development in the treatment of syringomyelia as such, although there has been considerable progress in the treatment of spinal cord injuries and spinal cord deficits. And I think we will see major improvements in the years to come. I also want to dedicate this talk to Harvey and many of the other patients I've had an opportunity to treat over the years. And here we go. Next, please. Next. So I want to talk basically, for a start, about the pathophysiology. And as some of you already know, spinal fluid, which we call CSF, cerebrospinal fluid, pulsates synchronously with the heartbeat and with breathing. And with every heartbeat, there's, as you can imagine, a little bit more blood in the brain when the heart contracts, and that displaces the corresponding amount of spinal fluid out of the cranial cavity into the spinal subarachnoid space. Next. And when the spinal fluid normally goes up and down, once the heart relaxes, the fluid goes back up and it circulates and is replaced in all of us all the time. But when the spinal fluid pulsations encounter a partial obstruction to its flow along the spine, it then acts as if it becomes easier for the spinal fluid to enter into the spinal cord itself than to travel along its outer or peel surface. And this is obviously facilitated if a spinal cord injury has broken down the tissue so it becomes more permeable to the fluid traveling into the cord from the subarachnoid space. Next. And there are a number of different obstructions that we can recognize. The most common, obviously, is a scar from the spinal cord injury, or for that matter, as you will see, also from surgery. Other common causes of scar formation are meningitis, that is to say, infection, blood in the subarachnoid space, which could be either from an injury or from a hemorrhage of a blood vessel, or from a foreign substance that is introduced into the spinal fluid, such as we used to do for some studies that are no longer practiced. Bone fragments from an injury and a spine deformity can produce an obstruction to this flow, as can a disc. There are arachnoid membrane cysts, and we're not quite sure why they originate, whether in fact they represent some remnant of an old injury or whether they're just developmental. And finally, tumors, both tumors within the spinal cord and tumors resting on the surface of the spinal cord can produce obstruction to the fluid flow. Next. So in that sense, syringomyelia can be regarded as a symptom of subarachnoid stenosis. Next. And we think of the spinal fluid then becoming a relatively isolated compartment. It's in the craniocervical junction in Chiari cases, and it's below the traumatic scar in post-traumatic syringomyelia as an example. Next. So using that as a basis, you will understand that the treatment of post-traumatic syringomyelia, which we will talk about first, has to be directed at eliminating this partial CSF obstruction at the spinal level. Next. So how do we identify such a partial obstruction? Today, MR scan with or without contrast is really the basic technique used, but there are situations where even today myelography combined with CT scanning is very helpful. We use the latter to look for delayed flow of contrast, and myelogram also allows us to look at a block and see how far it extends above and below the block so that we can deal with the entirety of the blockage. Next. Next. So myelography can be helpful, particularly when there's a serous cavity without an identifiable scar, as you'll see in a moment, sometimes with a diffuse or honeycomb syrinx, in the identification of an arachnoid cyst, which may be difficult to see otherwise, is already mentioned, to bracket and show us the full upper and lower limits of a focal scar. Next. And MR scanning, although very useful, in the brain we have certain techniques today that show us flow obstructions, but they're not available for the spine for various reasons. And so an obstruction may be missed on MR scanning if the cuts are not in the imaging in the plane of the scar itself. And again, the full rostrocaudal extent of the focal obstruction may, for that reason, be difficult to define because it may be out of the plane of any one cut on the MR scan. Next. Preferably, myelography should be performed by a C1-2 puncture so that we can use the full length of the spinal subarachnoid space to image. Next. So we're going to talk about post-traumatic spinal cord cavitation or post-traumatic syringomyelia. Next. This is an illustration taken from Dr. Millerat's paper, and Dr. Millerat, of course, as some of you know, was very active in this organization. And it shows very well how disruption of the spinal cord, I unfortunately cannot use a pointer in this presentation, but you can see it in the upper picture, allows fluid to travel into the substance of the spinal cord from the subarachnoid space. And this is a very important aspect. Next. Now, there are some characteristic features of post-traumatic spinal cord cavitation. One is that the spinal trauma may have been relatively trivial, and it may be something that the patient had no immediate injury or loss of neurological function, and it can also be true of minor surgical interventions. But the reason for the long time delay which may occur between this trauma and the development of syrinx is that this scar tissue has a tendency to build up over a period of time and thicken. And so the classical picture is that somebody may be well and may have forgotten about the injury and suddenly has a severe cough or sneeze, and with it, loss of sensation above a certain level of the injury. Next. So this is from an old paper, but it highlights the importance of the symptoms and pain on coughing or straining and sneezing. It is one of the more common ways in which post-traumatic syringomyelia develops. Pain, spontaneous or loss of sensation, and excessive sweating above the level of the injury, because sweating is not possible below the injury, are all common symptoms. Next, please. And the incidence of recognition of spinal cord syringomyelia has increased, obviously, with the advent of MR scanning, as you can see. Next, please. So it's important to understand why not every patient who has a spinal cord injury develops syringomyelia. Next. We all are born with a central canal in the spinal cord, and usually this disappears by age 10. Next. This is an example of it, and here you see this cavity within the center of the spinal cord. This is completely normal and is lined by normal cells. Next. This is a paper from Japan from about 25 years ago, and it shows how with every decade there is less and less of this residual central canal. And you can see over on the right side, by the time the person reaches age 10, less than 20% of people still have a residual central canal. But that said, in this study out of Japan, there were people who were over 100 years old who still had a small remnant of the central canal. And this is a very important thing for all of us to understand. Next, please. Because this has a very typical shape. You can see it has a sort of a spindle shape and tapers upward and downward into a fine line. And it's very, very different from the syrinx. Next, please. This is in the cervical region. Here's one in the thoracic region. Again, a very symmetrical cavity extending into a line both above and below. Next, please. And on axial images, it's completely round and central and does not have a expansion of the spinal cord as such. Next, please. And it is very important to distinguish between this hydromyelia or residual central canal of the cord and true syringomyelia, which is a distended cavity and is often irregular. A residual central canal does not present symptoms. And when I see a patient who has symptoms and the only finding on imaging is a residual central canal, I look for other causes of their symptoms. And I can tell you that in my practice, because radiologists often use the term syringomyelia for this residual central canal, it is a not uncommon finding in patients I see these days. Next, please. So, arachnoid cysts and diverticuli are what we're going to talk about next. Next. And here is an example of a patient who had a syrinx cavity, and it was not apparent why this syrinx cavity existed. And we went on to myelography. Next, please. And here you can see with contrast injected, there's a blockage above and below. You can actually see, particularly on the picture on the right side, the concavity of the contrast formed by the arachnoid cyst. Next. And here we are showing you the membrane of the arachnoid cyst. It's that slightly bluishly discolored line that prevents the normal flow of spinal fluid in the subarachnoid space. You can just see the spinal cord through the normally transparent arachnoid below, and the dura has been retracted out of the way. Next, please. And here it is, the same patient after surgery, and the syrinx cavity is gone. Next, please. This is another case. You see the syrinx cavity in the lower part of this T2 weighted MR scan. Next. And here you can see the lower extent of that goes well into the thoracic region. Next. And this was a very unusual case, which I have never forgotten, in which the obstruction to the subarachnoid space was formed by an arachnoid diverticulum, which I've illustrated in the drawing that I made after surgery, and this produced the settings for the syrinx. Next. Here it is with indigo carmine no longer available, but we use something else these days, showing this arachnoid pouch within the subarachnoid space, and we removed that. Next. And here it is postoperatively, syrinx is gone. Next, please. And you can see the area of the surgery. There's just a tiny bit of fluid left at just above the surgical incision site. Next, please. One can have post-traumatic syringomyelia without a bone deformity. Next. And it is important to define how severe the subarachnoid stenosis is, whether it's complete or only partial. And we already talked about the fact that it's important to find out the full extent of the subarachnoid stenosis above and below. And if the scar is in the high cervical region, it may present a very difficult and different situation. Next, please. Again, we talked about this. Next. Shunting in some of these patients, when there is no focal scar, may be the only option available, and shunting into the subarachnoid space is probably the best way of doing it rather than into the chest cavity, although sometimes we still have to do that. Next. Next. So here's an example. Again, you see the syrinx cavity in the lower portion of this cervical MR scan. Next. Here, in contrast to the residual central canal, you can see that this is slightly irregular and it is not in the center of the cord. Next. Again, the obstruction to contrast on myelogram, and this defines the arachnoid cyst. Next, please. And here it is outlined by dye at surgery, and you can see how the flow of spinal fluid is obstructed by the scar. Next, please. And here, the same patient after surgery with collapse of the syrinx cavity. Next. And again, on the axial image, you no longer see that hole in the cord. Next. This is another case before surgery, large syrinx cavity. Lower part is not, the obstruction is not clearly seen. Next. And here it is on the MR scan, you can see the blockage. Again, unfortunately, I can't point to it, but you can see the change from dark to light in the midsection of this scan. Next. And here we are aspirating the syrinx cavity and resecting it later on. Next. And placing a dural graft to expand the subarachnoid space, which is one of the techniques we use to create, if you will, a bypass for fluid to go past the obstruction. Next. And here's the same patient after surgery. Next. Bone deformities from an injury can also obviously produce a blockage of the subarachnoid space. Next. And this can be useful to relieve the bony obstruction. Next. Here's an artist drawing how an injury in the cervical spine can produce obstruction of the subarachnoid space and a syrinx cavity as drawn by the artist. Next. And the correction of this will allow the syrinx cavity to collapse. As the artist has shown here, it doesn't disappear completely, but it becomes much smaller and no longer exerts pressure on the spinal cord. Next. Here is an actual case. You can see the deformity of the spine from the bone in the front, and you can see the syrinx cavity as the dark, somewhat irregular cavities in the cord going all the way up to the base of the skull. Next. After surgery and decompression, syrinx hasn't disappeared, but it's smaller, and we have techniques today that would even probably allow for somewhat better relief of this obstruction and recreation of subarachnoid space than was practiced at the time I did this procedure. Next. Here's another case where a similar kind of situation in the lumbar region, and you can see the irregularity in the bone in the front and the cystic cavity in the spinal cord behind it, lobulated. Next. And the syrinx cavity extends all the way up into the thoracic region from this lumbar injury. Next. Even extends into the lower cervical region. Next. And here, after removing the obstruction, you can still see a remnant, but the syrinx cavity is much smaller. It's partially collapsed. Next. And even in the upper region, it is, with a dural graft, it is partially collapsed. Next. I already alluded to the fact that surgery from tumor removal can lead to scar tissue formation. Next. And here is a case in point. Next, please. And here's the scar that was encountered by us in this patient who had undergone prior removal of a benign tumor of the spinal cord, but there was scar tissue formation in the subarachnoid space that created the mechanism by which syringomyelia developed. Next. Diffuse scarring in the subarachnoid space, such as may occur following meningitis or a hemorrhage, may not lend itself to resection of a scar such as I've shown. Next. Here's an example of that sort, and I wouldn't know where to do the operation in this case. This patient had had a prior subarachnoid hemorrhage. Next. And sometimes, I already mentioned this before, if the syrinx scar is very high in the spinal subarachnoid space, trying to resect the scar may risk making the patient dependent on a respirator because of the location of nerves to the breathing mechanism in this area. Next. Here's such an example. And in such cases, what we do next, here's another one where the injury was high up in the cervical cord. Next, we divert the fluid next, so we don't have to manipulate the cord itself. We just divert the fluid pressure away from this obstruction. Next. And this is just an artist's diagram to show how, as you see in C, diverting the fluid away from the scar allows the syrinx to get smaller. And in this particular patient who was severely disabled, it made the difference between his ability to manipulate the controls on his wheelchair by hand. Next. So thecoperitoneal shunts are best for post-inflammatory syrinxes with diffuse changes. Next. Here's another example. This patient developed a syrinx in the cavity after tumor resection. Next, and all we did was divert the fluid away from the area above the cavity and it disappeared. Next. So syrinx shunting, I will talk about briefly in conclusion. Next. We use a guide to pass this catheter, which has multiple perforations. Next. And we drain the fluid out. Here it is going away from the spinal cord. Oftentimes today we would put it into the green space, the subarachnoid space in this diagram. Next. And here's an example of such a case. Next. And the syrinx cavity gets much smaller. You can actually see the shunt tubing at the bottom right of this illustration. Next. Here is this same patient with a diffuse post-inflammatory syrinx. Next. Oh, I guess that's a repeat. I'm sorry. So shunting is, however, not the ideal way of treating syringomyelia and has complications which we cannot avoid. Next, please. This is from our own study. For reasons which some of you, unfortunately, I can't see you, but you'll understand that if the syrinx cavity collapses around the tubing that has multiple openings, and since we're talking about a living tissue, what happens is that the tissue will grow into the shunt and obstruct it. And the shunt can also be tethered to the dura and to the spine, and the other things you can see for yourself are obvious complications for malfunction. Next. Next. This is an example of a patient in whom I had to take the catheter out, and you can see how tissue grew into the holes in the shunt. Next. Next. This was a patient who had a shunt, a syrinx cavity with two chambers, and we inadvertently drained only one, not recognizing that the two chambers did not communicate with each other. Next. Next. Here, this is an example where the shunt holds up the spinal cord to the dura and the spine. Next. And infection, abscess. Next. 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 So syrinx shunting is considered a last resort when we have nothing else that we can offer a patient. Next, please. And whenever possible, we try to put it into the subarachnoid space. And when a full laminectomy is necessary to do it, we recommend immediate fusion stabilization. Next. This is what I've already talked about. Next. 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 So this is just to show you that all types of shunts have some kind of complication rate. Next, please. And next. All types of procedures have complications, but this is what we did some years ago. We've done more since. Decompressive laminectomy with duroplasty and syrinx shunting is very commonly done still for patients who have no other alternatives. Next. And you can see that it's not uncommon for these patients to require more than one procedure. Next. And our most common situation was post-traumatic syringomyelia, and you can see that quite a number required reoperation. I would call your attention to the fact that there are, however, many yellow bars in this, and this means that when we shunted the patients, the neurologic deficit stabilized and did not progress, and that's really the aim of treating these patients. I think I will stop here and leave time for questions if there are any from the audience. Thank you.
Hi, thank you, Dr. Batzdorf. So if you see somebody who has a traumatic event that possibly can lead to spinal cord injury, but at the time there's no indications, what would you look for in terms of treating them preemptively, and what are accessible treatments now?
That's a very good question. I think one of the things that we would look for is whether there's any bleeding in the subarachnoid space following the spinal cord, the spine injury. And MR scanning allows us to identify bleeding in the subarachnoid space, hematoma. I've seen one patient not long ago who had a hematoma, and the doctors said, "Oh, this will clear up." Well, the unfortunate thing is that the blood is resorbed, but it's in the nature of the healing process that when the blood is resorbed, it may lead to scar tissue formation. And it needs to be understood that scar tissue formation is a very complicated process. And in some people, and we notice this in our skin too, a scratch may produce no scarring. And in other people, a scratch may produce a disfiguring hypertrophic scar. So I think the important thing is to recognize bleeding and to treat it appropriately. Then I would recommend that if there's any question, one can follow up with an MR scan at a reasonable period of time afterwards, whether that be 6 months or a year, and possibly even one more time point, just to see whether there is any indication of early scar tissue formation and blockage of spinal fluid. Does that help? Well, it depends. Some people will have treated spinal cord injuries, spine injuries with steroids. Obviously, steroids have their own side effects, and I would be loath to do that. I think it is important to mobilize patients early on, because it's not a coincidence that many of these scars form in the thoracic region, probably because patients lie on their back and the blood settles into this area and scars in that area. You're welcome.
Are there any more questions? If not, thank you, Dr. Batzdorf. John,
Okay.
if you could thank
Thank
Dr.
you very much
Batzdorf at the
for
computer, and
letting me
then we
present,
can log off.
and have a good Thank you and have a good rest of the meeting. Greetings to everyone.
Thank you.
Thank you for making this possible for me and for your technical help. Thank you. Bye-bye.